Everybody, this is Broadcasting ADHD Europe. This is Broadcasting ADHD Europe. I'm Hans van der Velde. I'm Vice President of ADHD Europe. In daily life, I work as a coach. I coach employees for employers. And next to that, I'm the chair of the Science Committee of the Dutch Association for People with ADHD and Dyslexia. Here you also see Viljo Wilding. He is our new board member. Hello, Viljo. Good evening. Happy to have you here. Viljo is moderating and organizing the whole technique and supporting us tonight. But the star of the night is Antoni Ramos. Welcome, Antoni. And I hope you can introduce yourself in a minute, because we are going to talk today about ADHD, addiction, substance abuse, and everything that's got to do with that. So please, Antoni, can you introduce yourself?
Thank you, Hans and Viljo, for the introduction and for the opportunity to be here with all of you around Europe and beyond. And I'm very happy to be here and to sharing some scientific information about these two conditions, ADHD and all the field of addiction. As said Hans, my name is Antoni Ramos-Quiroga. I am professor of psychiatry at the Autonomous University in Barcelona, Catalonia, Spain. I am also the head of the Department of Psychiatry in the Vall d'Hebron University Hospital in Barcelona, and the president of the Innovation Commission of this hospital also. And I am working over the last 25 years in the field of ADHD across lifespan. We organized the first public department of psychiatry that had an ADHD department that we treat and we deal with ADHD, but not only in childhood, also during the adolescent and also during the adulthood. It was the first program in Spain treating ADHD in adulthood.
Yeah.
I'm happy to be here, as I said before.
Yeah, you still work as a psychiatrist, but in a clinic as well, see clients,
Yep.
see patients. Oh, okay. Yeah, not only the scientific, but also the day-to-day practice. Yeah.
I have one specific day on the public hospital and also one specific day in my private office in Barcelona.
Yeah. Well, I propose we get started first with your presentation, and every now and then I will interrupt you if I don't understand really what you mean, or to make it more clear. And afterwards,
Awesome.
I've prepared some questions, and the public can ask questions through the comments. Viljo, can you please explain where people can ask their questions?
Yes, of course, Hans. If you are on Facebook or on YouTube, you'll have just seen my sloppily typed comments there. You can put your questions to Tony in the comments, and Hans and I will be able to read those off. And as you can just see, I can put it on screen like so. So if you have a question for us, please feel free to put it in the comments, and Hans and I will read that out to Tony for you shortly.
Yep. Okay.
Okay. Now I am sharing my slides. Yes. It's here. Can you see the slides?
Wonderful. Yes, of course. Yep.
Okay. Whoops. Sorry. Okay. As we said before, the topic of today will be around ADHD and addiction and substance abuse and substance use disorders. Here also you can find my Twitter account. If you have any doubt or any question, you can contact with me. I will be happy to respond. And also, as I said before, thank you to the ADHD Europe, not only for the invitation, but also for the good job that you are doing in favor of all the people with ADHD. And your work is essential in terms to have more recognition, more support, and more resources for ADHD around Europe. That is my conflicts of interest. that I want to share with all of you. I have a research fan, and also I have been an advisor or a speaker of several drug companies or tech companies or public foundations, as you can see here, and research institutes. This arrow, this slide, to me is absolutely crucial to understand better ADHD. ADHD, as you know, is a condition that where the majority of the people have an duration across lifespan, not only during the childhood. But moreover of the continuity that is, I think, at that moment very well known about ADHD during the adulthood, to me, this slide is very important because we can have the opportunity to make prevention. Why prevention? Because we know very well that ADHD starts during the childhood period. And also we know very well that ADHD itself is a risk factor for having all of these questions, all of these situations, to smoke tobacco, to use other substance of abuse as cocaine, cannabis, or alcohol. And if we treat correctly, appropriately ADHD during this period of time, we can do prevention and reduce this risk. Also reduce the risk, for example, for poor self-esteem during the school age, or reducing the academic failure or academic problems. And if we got a good treatment of ADHD here, a good treatment means all of the evidence-based treatment that we have available at the moment, psychological treatment, social treatment, pharmacological treatment. Also, we can get a better condition here during the adulthood and reducing also the risk of addictions or the risk of car accidents. Later on, I will be sharing with you very important research talking about this capacity or this possibility to do prevention when someone have an ADHD in order to reduce this metastasis, if you want, of ADHD, like addiction disorders. If we pay attention to the other side of the coin, there are a lot of people in the setting of community centers for addiction, but also they have an ADHD. And that is a summary of the research about this topic. What is the rate, what is the percentage of adolescents that have ADHD when they consult for problems with substance use disorder? In these addiction centers, the majority of the studies are saying to us that around 20% of these adolescents with substance use disorder also have an ADHD. But in adults, it's the same situation. We know the ADHD in general population, adult general population, is around 2.5% or 3% of the general population. But the prevalence of ADHD in patients that are seeking treatment for substance use disorder, the range is very high, around 2% to 83%. There is a variety of these results regarding the methodology of these studies. But the average in a recent meta-analysis and a study that is like a big summary of the previous study is that more than 20% of these adults seeking treatment for substance use disorder also have an ADHD. And that is very important also, because making a good diagnosis of ADHD in this moment is a new opportunity for these people to stop the relapses in the substance of addiction. Here, I am sharing with you a very important study. That is the ES study. and was made or driven or carried out inside the umbrella of the ICASA Foundation, the International Collaboration on ADHD and Substance Abuse, that I am member. And here we studied the prevalence of ADHD in adults seeking treatment for addictions. And was a very impressive sample, more than 1,000 patients in France, Hungary, the Netherlands, Norway, Spain, Barcelona, Sweden, Switzerland. And we got a rank between almost 8% and 30% of this population also have an ADHD. As average, it's around 13-15% of these patients got an ADHD or had an ADHD. Repeat, it's very important in the setting of substance abuse also make a good diagnosis of ADHD.
How do you explain the differences between all the countries?
Well, that is a very good point, Hans. One aspect, for example, here that is very important in Norway is the highest, they have the highest range, probably because there are more sensibility on the diagnosis of ADHD in the northern countries, and also probably because the specificity of these substance abuse centers having more patients with ADHD. But in general, for the rest of the countries, are quite similar. In our case, was 10%, in the Netherlands, 11%, 16% in France. Yes, and that is the question. Probably in the Scandinavian countries, we have the highest prevalence because there are more. The centers receive more and more patients with ADHD, and they are more ready for the diagnosis of ADHD at that moment. Yes, this study was.
So based on these figures, you could say that if professionals all over Europe, psychiatrists and psychologists, pay more attention to both addiction and ADHD, these figures will grow if they do it seriously and professionally.
Yeah, absolutely, absolutely. At that moment, we know that there is a debate about the overdiagnosis of ADHD. But the reality, in fact, is that when we are studying in different settings, in forensic setting, in criminality settings, or in addiction settings, in the real world data, there is an underdiagnosis of ADHD. And the most important is that there is an under treatment of the condition ADHD in this population. And for that is very important, this kind of webinars, not only for the family and for the patients, but moreover for professionals, because we need more professionals with good knowledge and with expertise doing the diagnosis of ADHD, in this case in adulthood or during the adolescence. Sure. Another very important aspect is that, as probably you know, ADHD itself increases the risk of mortality and mainly for non-natural causes, for example, car accidents, or also the use of substance of addiction. The risk is the double of the general population, as you can see. But also when we combine it, ADHD plus substance use disorder, the risk of mortality compared with general population is more than 5 times more risk in this population, ADHD plus substance use disorder, than the general population. And also, when this population with ADHD and addictions had also conduct disorders or antisocial personality disorder, the risk is almost 9 times the general population. And that profile, this clinical profile, as you can see here, ADHD, addictions, and antisocial personality disorder are very frequent, are very common. It's not unusual on forensic settings or justice setting or in criminalities in prison settings. And for that, it's very important here another new opportunity. If someone is in prison, someone is in these settings, it's not the end, it's another opportunity to make appropriately the diagnosis and also to have the opportunity for these patients to have a right and a good treatment for ADHD and also these addictions.
You could say that the addiction, together with ADHD, is the gate to crime, especially when you're born with ADHD, of course. Then when addiction develops, that's one of the gates to crime and to prison and troubles, etc. And
absolutely, Hans. And that is a new opportunity. I prefer to view that, not or to see that, not with the idea that, oh my God, someone is in prison or with these criminal settings. Obviously, it's better not have these situations. But if someone is in this situation, it's a good opportunity to make a right diagnosis of ADHD, and also the most important, to treat with all armamentarium, with all possibilities that we have, with psychological treatment, with drug treatment, and to try to control ADHD and also this substance use disorder. Here in the slide, for example, is an explanation. What is the clinical relevance when ADHD runs together with substance use disorder? We can see more severe ADHD symptoms, more impulsivity, also a worse response to the pharmacological treatment in general, and also more severe structural brain abnormalities. But on the other hand, when someone with substance use disorder in this typical community center for addiction or detox unities, if someone has an ADHD, there are greater severity of substance use disorder, very important earlier age at onset. This substance use disorder started during the childhood, during the early adolescence, and for that it's critical to make a good diagnosis of ADHD during the early childhood. And more severe clinical factors, and also more frequent of relapses in this case. And the transition from the abuse to dependence is fast in people with ADHD. This clinical picture and this clinical relationship with both disorders point out that probably there are genetic risk factors that both disorders are sharing. And that is the case. Here, I would like to share with you one paper of our lab in collaboration with other international groups, as the group of Dieter de Montes in Denmark, and also the Psychiatric Genomics Consortium, and the group of Jacqueline Vink in the Netherlands, or Steve Ferron or Barbara Frankel from Nijmegen, or Benjamin Neal in Boston. Here in our lab, we studied what is first, ADHD or cannabis use? What is first, the egg or chicken in this case, or chicken or the egg? In this case, we studied a very large sample of patients with ADHD and also patients with cannabis use, and clearly we found that the genetic risk of ADHD is in itself a predisposition to cannabis use. And here you can see the statistical significance is very, very high. It's a causal effect of ADHD on lifetime cannabis use. And also the risk of cannabis use in people with ADHD is almost 8 times to the general population without ADHD. This study was published last year in Molecular Psychiatry. That is a very high impact factor, very important scientific journal. Also, our group, during the last year, we studied other comorbidities, other causalities or genetic overlap between ADHD and other substance use disorders. Here you can see this genetic correlation result with different addiction conditions: alcohol dependence, smoking initiation, cocaine dependence, ADHD itself, smoking cessation, cigarettes per day, live cannabis use, or age of smoking. Here, ADHD clearly found absolutely a highest correlation with ADHD itself, obviously, okay? And for that, the dot is very, very dark and very big. If you have more blue color and more higher size of the dot, we have more genetic correlation. For example, with alcohol dependence, there are genetic correlation with the smoking initiation, also with cocaine dependence, or with the number of cigarettes per day. More ADHD, more cigarettes per day. And here, for example, the age of initiation. People are initiating, starting the use of nicotine earlier, and it's very related with ADHD, and you can see here. As summary, we can say now that ADHD itself, the genetic risk of having ADHD itself, is a genetic risk for having other addictions, in this case, cannabis use or smoking or alcohol addiction.
In genetics, we talk about mutations or variants, and if you compare the genetics that only are related to addiction, the genetics that are only related to ADHD, and then the overlap genetic mutations that relate to ADHD as well as SUD, do you have quantitative figures about that? Or is it, where is the genetic relation in quantitative terms?
We know, for example, that there are genes of the serotoninergic system or another system that the name is snare system that is related about the release of dopamine to the synaptic cleft that are related with both, with addictions and with ADHD. Now we know that there are a rate of genes, of this puzzle of genes, that are sharing between both disorders. And the job and the challenge that we have now is to know correctly what type of genes, what type of genetic variants are related with this increased risk. There is under construction, under study, these very specific molecular aspects. Here in the slide, for example, you can see the different subcortical, that means under the cortex. Here is the cortex, and all of these areas are subcortical, under the cortical area. That is a picture of the brain in the lateral view of the brain. Yes, it's like if you open a brain in the health and you can see the lateral view. There are several structures related with ADHD, and one of them is the amygdala. Amygdala is a structure related with impulsivity, with emotions, with the emotional dysregulation. Also important for ADHD and also important, very important for borderline personality disorders, and also important for addiction. But the most important structure for addiction here is nucleus accumbens, because it's the area, is the nucleus of all drugs have an impact, and that is a nucleus that is absolutely of interest on the reward system. When someone is doing an activity and this activity make us pleasure, is because we have like an activation of this nucleus. And cocaine, alcohol, all of the drugs of abuse, and also the behavioral addiction as gambling play, uh, or sex addiction or food addiction, yes, has an impact on this nucleus. And we know that modifications, alterations of this nucleus are related with more risk of addiction. And also, this nucleus have difference in people with ADHD. And also, these differences could be one of the points that increase the risk more than the genetic risk of having addiction in people with ADHD. That is a part of genetic basis or more biological basis, but also we know, and that was a paper of one of my PhD, Mariana Nogueira, and was published years ago in 2014 about what clinical aspects are related with addictions in adults with ADHD, and what of these clinical pictures in the early age, clinical and development. And we clearly found, you can see here, that accident prone is related with more risk of addiction during the adulthood, but also sexual abuse. Sexual abuse during childhood increased in more than 3 times the risk of having addictions or be suspended from the school, double the risk, or having ODD during the childhood, oppositional defiant disorder or conduct disorder also increase the risk of having. But on the other side, to be as a personal trait, to be fearful, to have anxiety, decrease the risk of having addictions later on during childhood. It's important because if we know this clinical characteristic and we have a child with this characteristic, is an opportunity to treat correctly these conditions to prevent the PTSD, the post-traumatic stress disorder related with sexual abuse, because that could be also of high interest, reducing the risk of substance use disorder later on.
Yeah, sorry, I have a question relating to sexual abuse and other forms of abuse and mistreatment, because we know that in an ADHD family where impulse control is a little lower, all kinds of incidents may occur. But that was one of my questions. Addiction is also, let's say, sedative. You suppress your negative feelings with it. And I can imagine that in case of abuse, even sexual abuse, there are, of course, negative feelings that stay for years. And then addiction, using alcohol or whatever drug, is very helpful to put your feelings away. Do you agree? Do you recognize that in your clinical practice?
Yes, Hans, that is the hypothesis of self-medication. When someone has a PTSD, post-traumatic stress disorder, it's not uncommon, it's usual to have problems with alcohol or other drugs. And probably, maybe, the first time that people with PTSD disorder are using this or abusing of this substance, probably the first time they got some positive results. But the problem is that use drugs with the risk of addiction to treat any mental disorder or any mental condition is the highest risk for having of an addiction later on, yes, or being dependent of this substance. Well, now the good point is that we have several international guidelines and recommendations that can help us to manage better ADHD with substance use disorder, or to recognize better ADHD in population with substance use disorder. One is the very well-known NICE guideline. There is the new update from 3 years ago. And also the European consensus driven by the Adult ADHD Network, leading by Sandra Koik, and the section of neurodevelopment disorders across lifespan from the European Psychiatric Association. During the time that I was the chair, we developed this updated European consensus statement in order to make clinicians, to help clinicians to diagnose and treat ADHD in adulthood right and appropriately. Yes, both the guideline and the consensus are open access and free available on internet, and you can get free samples of these two papers. Well, regarding the pharmacological treatment, we have a set of treatment, as you know, for ADHD. We have stimulants, we have non-stimulants, and also non-licensed drugs that can be useful for ADHD across lifespan, as, for example, in this case, bupropion or other non-licensed drug for ADHD. Well, all of these treatments, we can use these treatments for people with ADHD and also with substance use disorders. There are a set of evidences that could be useful, that could be safety to use these drugs with this population. But more, I am a psychiatrist, I am a doctor, physician, more than the pharmacological treatment, please keep in mind that it's absolutely necessary to introduce, to combine with this pharmacological treatment, to combine psychological treatment. There are several psychological treatments that got good results with addictions, cognitive behavioral therapy, family systemic therapy, and also mindfulness could be options. And modifications of these treatments were psychological treatments were also tested for people with ADHD plus substance use disorders. Previously, during this presentation, I said that there are a set of very, very, very important studies that shown us that it's possible to treat ADHD, and also it's possible to prevent these very negative outcomes related with ADHD. That is a very, very important study published in the New England Journal of Medicine, one of the most prestigious journals in medicine. And the group of Henry Larson in the Karolinska Institute, now in Örebro also University, they found in a very large sample, the thousands of subjects with ADHD, that the right treatment with pharmacological treatment for ADHD can reduce the risk of relapses on criminal acts or criminal actions, yes? And that is very useful in terms of prevention. The same for suicidal behavioral or for serious transport accidents. And in this case, and for very important for the talk of today, do you know that during years and years and years, some people argue that to treat children with ADHD, we increase the risk of having more addictions in the next future. That we can say now that that is a fake news, because with a very scientific papers and with a very scientific right methodology, we know that treatment with ADHD during childhood will reduce the risk of substance use disorder later on. And that is very important and very useful for all the families.
I do like the saying you used a few minutes ago. It is an opportunity, because on the one hand we have to talk about the more or less disastrous symptoms that ADHD can have in certain circumstances, but that would be only negative. But I'm happy with your remark. This is an opportunity with early intervention to make it better. So
yeah,
thank you for this. It is an opportunity, and it's not all bad. It's also a chance of a better life for many people.
In this case, Hans, I like to name it ADHD as the disorder of opportunities, because it's right, it's true that someone can lose a lot of opportunities without a good diagnosis and without a good treatment. But on the other hand, if we got this treatment, if we got this clinical support, we can gain a lot of, we can win a lot of opportunities, and we can, I think, we can take the control of our own life, and to have the opportunity to have an optimus life in this sense, with a good quality of life. And that is also possible. I know that doctors, we are speaking all the time about negative repercussion or outcomes of every disorder, because one condition is a disorder because impact negatively in general in the population that are suffering this disorder. But on the other hand, I think it's very important to know that having one disorder is sometimes for the life of the people, or the people affected, could be a possibility to have a different perspective on life. But and also, if you have a right treatment, it's an opportunity to win more quality of life. And that, to me, is very, very important. It's not only optimistical in self without sense. I think it's important because it's based on evidences and I think very strong and powerful studies. Now, also, I would like finally to share with you, all of you, that there are a lot of investigation, a lot of research with this comorbidity, with this situation of ADHD together with substance use disorder or addiction. In this sense, I would like to highlight the use for the awesome work that ICASA Foundation was made over the last years. We are working together, several sites, several countries around Europe, and also in South America, in Africa, in North America, in order to understand better ADHD plus substance use disorder, and to know better what is the best and the right treatment. Yes. Now, I would like to share with you several open access also papers. That the first was an international consensus about the screening, the diagnosis, and the treatment of ADHD plus addictions. Here, there is a summary of all the clinical trials, the randomized, double-blind clinical trials. That means clinical trials with a high level of quality or high level of good methodology, combining the treatment of ADHD plus treatment of cocaine or polydrug abuse or opiates or alcohol or amphetamine abuse or nicotine, and the drug tested also combine it in all of these clinical trials with cognitive behavioral therapy. The typical methodology is to test if, for example, in this case, methylphenidate plus CBT, cognitive behavioral therapy, is better than placebo plus cognitive behavioral therapy. It's a very strong power of placebo because the arm of placebo were getting treatment with cognitive behavioral therapy at the same time. And here are the results. The majority of these clinical trials, we found that it's possible to treat ADHD to reduce the severity of ADHD. And in the most recent clinical trials with the most powerful methodology and the highest doses of, in this case, methylphenidate or mixed amphetamine salts, these studies in Sweden and also in New York, they found a positive effects treating together ADHD and substance use disorder. And that is a very important message. We need probably maybe to use higher doses in this population than the general doses that we are using in people without substance use disorder. In the previous study, the doses was very low when we compare with the doses of most recent studies. We got also, we recommended several advice for clinicians. One is that it's very important to treat at the same time, in parallel, both conditions. Also, as I said before, it's very important the combination of psychotherapy plus pharmacotherapy, and also integrate as soon as possible both treatment. Yes. And so also
there was a question about this, and it's now at hand, so that's why I interrupt you. Sorry for that.
No.
There were two questions about abstinence. Why is total abstinence the best advice is one, but the other one is it standard that you first have to stop your addiction and then medication for the ADHD? I think that's old-fashioned, but you know the statistics. So abstinence and how to time out the stopping with drugs and the starting with medication.
Thank you, Hans. It's not an interruption. It's a very, very important point and I am very happy that you are saying these questions, or the audience are saying these questions, because that was one of the aspects that it's necessary to deal. This idea that before the treatment of ADHD is absolutely necessary to be under without using any drug, detoxificate. It's very negative in this sense, because we can wait years and years and years and years and years. Because I said before, ADHD increases the risk of the relapses of substance use disorders. And for that, we consider that it's important. If you are using a lot of drugs and all, it's impossible to treat anything. But if the patient are reducing the severity of the addiction, and also we have the opportunity to have a detox in a detox unit, it's a good moment now to start the treatment, because we know that the combination of both treatments are without health repercussion, are not with negative effects in terms of adverse events or in terms of bad tolerance. Yes, and that is important to reduce the addiction, but to start as soon as possible the treatment of ADHD, because that will be very useful in terms to prevent a new relapse of these addictions. And also, as you can see here, recommended these long-acting stimulants, yes, extended release stimulants, or in patients with antisocial personality disorders that we perceive that could be possible to have a misuse of these drugs, to use, in this case, non-stimulant drugs as atomoxetine, for example. Also, the latest recommendation or a statement that we published on the umbrella of ICASA was the first international recommendations for ADHD and addictions, but in the adolescents, in teens. We have a set of 10 recommendations for the treatment. There is a summary of the first 5. In general, it's the same recommendations, and the consensus was very high. It's possible to treat. We have good pharmacological treatment, and it's absolutely necessary to start doing pharmacological treatment and also psychological treatment. In this case, it's essential to introduce in this treatment the parents, the family, yes, to get right information, appropriate information, and to work together in order to prevent the relapse and to decrease the stress and anxiety on the behavior, yes? And also the same recommendation about the long-acting stimulants, or in case of risk of misuse, to use non-stimulant atomoxetine, or why not also guanfacine, yes? And for us, the most important is that it's possible to treat. We have good drugs, good treatments at that moment. Obviously, we need more research, and obviously we need more personalized treatments. But at that moment, it's possible to treat. It's possible to do the right treatment. Also, I would like to share with all of you a very new initiative that we are doing during this year. We started in April 1st this very important European project that also we have involved with patient organization, ADIS from the UK, and we are trying to know better what is this cardiometabolic risk of ADHD during a cross lifespan, and using novel methods within artificial intelligence and using apps for the monitoring what is the patient journey and what is the outcome after doing treatment with ADHD. And with this project, this name it time span, we hope to have this right treatments for ADHD in the next future, and to have more and more and more knowledge and more information about that. That is very, very, very important, this kind of projects that's funded with almost 6 million euros for the European Union. And this large grant is coordinated by Professor Henry Larsson from Oro and Karolinska Institute, and we are working together, several centers in Europe, and also patients associations with university and scientific center. And that is important, this collaboration of together people and patients. We had previous collaboration with all of us in COCA project or It To Be Nice project. And now this time span project, we hope that in the next 5 years, we have more information that could be very useful to improve the clinical outcomes and also the quality of life of patients with ADHD and families. And also, I would like to advise you and to recommend you to collaborate with your university hospitals or clinician settings in order to participate on clinical research, because that is also the only way to improve the knowledge and to improve the management of all of these conditions.
This is really fantastic. So thank you for bringing this up. As you know, we are ADHD Europe with members in 27 countries. And in the Netherlands, we've been advocating for continuous health monitoring, especially since we know that amphetamine medication does have some cardiovascular problems, and we, yeah, nice. Hello.
Okay.
Yeah, great.
We have a picture.
Yeah, great. And we went to Parliament, and we told in the Netherlands, our Parliament, that we would take, as a patient organization, we would take matters into our own hands and develop monitoring smartphones with sensors, etc. So I didn't know that this initiative existed. So I could say that we will promote this project in ADHD Europe, and our members just send us a bit more information. Maybe I'm not very much aware of the project. Can you? What is the name of this project? 5 years.
The name of the project, I said before, here you can see is Time Span Projects.
Oh, okay, yeah.
I'll remove our logo so it's more visible. There we go.
Oh, okay, yeah. Times. Oh, there it is.
I, for one, am very looking forward to joining the Timespan meeting tomorrow with Andrea on behalf of Addis. We're really excited to be involved.
Oh, okay. We are already involved. Yeah. Sorry, Anthony, we are already involved, of course.
Addis is here. Addis is here.
Yeah. Okay. Great. Fantastic.
Well, and finally, as conclusions, there is the overview of time span newly, and here. As conclusions, I would like to emphasize that ADHD and addictions are highly comorbid. They both are working together, running together. We have opportunity. That is, I think, is the word of the day, opportunity, to prevent addictions, treating appropriately right ADHD. We know that there is a high genetic correlation between both conditions. Also, we have several evidence-based treatments available, and that is a very positive conclusion. And also, to me, it's very important to remember that ADHD is very common. Also, addiction are very common in the general population. Almost 10-15% of general populations have an addiction. Probably for families, for patients, clinicians also, there is like a big storm in the future when both conditions are working or running together. But as said before, we can treat, we can prevent, and we can deal with both conditions. And also it's very, very important to remember that all patients seeking treatment for substance use disorder should be assessed for ADHD and receive the right treatment after confirming the diagnosis. That is my best advice for all the families and probably for all the clinicians. And as I said before, thank you so much, Han, Bilho, and ADHD Europe, not only for the invitation, but moreover for all your awesome job during these years of ADHD Europe.
Great, thank you so far. And some questions did already pop up in the public and in the comments. And I've prepared some questions. First of all, I like this closure rule of thumb. You say, if addiction, then always check on ADHD. Let's tell that to all clinicians and all the people who are listening. If addiction, always check for ADHD. I even can turn it around. If you are talking confidentially with a person with ADHD, always, I myself, in my coaching, I always bring up that I have stopped using alcohol some 10 years ago, and it was for a reason, you know? And then they come open and say, and 2 conversations later, they say, oh, Hans, by the way, you mentioned alcohol. Now I'm on cannabis and alcohol, and can we do something about it? So it's a rule with 2 sides. Do you agree with that? It's also
absolutely.
So that's something to take away for everybody present and pass it on. Some detailed questions first, and then I want to go into psychology and psychotherapy. But first, one detailed question. Is there a difference, or what's the connection of the symptoms of purely ADHD and the symptoms of long-term drugs use? Because as you know, people who have used a lot of drugs, they tend to look like ADHD.
Yeah, that is a good point and a good question, because several drugs of abuse can mimic or have similar symptoms, yes, as ADHD. But we know that ADHD is not a disorder that typically starts during the adulthood. We know all of the symptoms during the childhood, and that is the very important for making the right diagnosis, to have a good clinical history of the patient. ADHD started during childhood, in early adolescent, in early teens age. A patient started using drugs, and they continue using drugs, and they continue with ADHD. And that is the right diagnosis. If someone during the childhood didn't have any symptom of ADHD, any negative impact, a good school performance, and in adulthood, they have an addiction with cocaine and alcohol, and with some symptoms of hyperactivity, impulsivity, uh, probably, maybe, this is a patient without ADHD. They have an addiction, but not an ADHD plus an addiction, because it's critical the period of time during the childhood for having the appropriate and the right diagnosis.
Yeah, so I totally agree, because don't call everything that is restless and impulsive ADHD, because you might miss another diagnosis. Always be what we call differential diagnosis. So be critical and always discuss a diagnosis, let's say. Anyway, thank you. And then there was another question also a bit about this, that this lack of inhibition, disinhibition, may it be caused by drugs use. That's also, you said it already. So that people who have used drugs will be, if they have ADHD, will be extra impulsive. Is that, can we expect that? Is that a proper expectation?
Yeah, right. That is the case. If ADHD increase the symptoms of impulsivity, and also it's quite common to have, more than ADHD, a profile of personality with high impulsiveness, yes, and that combination with some drugs, for example, alcohol. Alcohol is like being someone without appropriate stop for this impulse, yes. And if you have an ADHD that is very high impulsivity, plus this drug that reduce the self-control of this impulsivity, obviously is a higher, is a highest risk of having issues and conflicts and problems during your day by day.
Furthermore, another detail, you mentioned addiction to sex or to gambling or shopping addiction, or people can get addicted to anything. Sometimes I want to check something with you. Sometimes I say, in a sort of analogy, addiction to shopping or sex is also substance abuse, only it's substance in your body. It's not external substance. It's always, there is a substance included, that let's say a neurotransmitter or hormones or whatever. Is that technically right?
Yeah, absolutely. That is the situation that, or the background that I said before. For example, we study here in Barcelona with people with gambling disorders, what is the risk or what is the rate of ADHD. And it's quite similar for the other substance of addiction, like alcohol or cocaine. Around 15% of these people have also got an ADHD diagnosis. But as we discussed previously, one of the very important points is that these people with both disorder have or had highest impulsivity, highest severity of these gambling disorders. And if we want to manage better both conditions, it's necessary to deal with both conditions, not only with gambling disorders or not only with ADHD. And also, we discussed it during my slides that these behavioral addictions, gambling or sex addiction, also the final point of activation is this nuclear accumbens on the subcortical structure of the brain. It's this nucleus part of the reward system.
Okay. Then something about men and women. You could say, I heard that men are more into substance abuse and other addictions. Are there any special addictions that women get into? Is there a difference in men and women? And is there an explanation for that?
Mm-hmm. There are more risk of substance use disorders in males than females in general. But it's interesting to know that females with these problems have a higher severity in general than males. There is the females with risk, or females in addiction, they got higher severity, yes? Mm-hmm. And what, for example, is a very interesting results with the study of the Danish colleagues about mortality that I presented, the relation or the correlation with substance use disorder. In this study of mortality, in general, females got highest rate of mortality than as males. Yes, probably for having these addictions, it's necessary these highest levels of impulsivity, more genetic disturbances, and we don't know why males and females have this higher risk than others. But the reality is that in clinical settings, we are seeing more males than females, but females are of highest severity or in general, they have a higher severity than males.
What I see, but it's not statistics, that's only experience, that the women I've known during the past 25 years is more into alcohol addiction when they have ADHD, and shopping and sex and gambling addictions, and males more in the explorative drugs like cannabis, cocaine, etc. But there's no real statistics about that.
Mm.
So another question about medication. You showed very clearly, thank you for that, that which medications work best for both ADHD and substance abuse, so that's clear. But now some people who really went into rehab, let's say, and we will come to a certain kind of rehab in a minute, but who went into rehab, they are so convicted that they don't want anything that sounds like amphetamine. So if you say dexamphetamine or methylphenidate, that's amphetamines, they are a little afraid of that. Is that a good alternative if they really have psychological problems with that? They are afraid to get mentally addicted, you know?
Hence, it's a very, very, very quite common, very frequent. People that are using grams of cocaine every day, 2-3 grams, they are afraid of using any drug treatment, yes, for depression, for ADHD, for anxiety. It's a paradox, yes, because they are using very severe and very negative substance, yes. Well, I need to say that is a mistake. if you have an ADHD and, for example, cocaine addiction or alcohol addiction, itself is a mistake to refuse and not to accept these drugs, because it's a huge opportunity for them to get a good response and a good outcome. Yes, obviously we need to respect the idea, or to respect the decision of everyone. Yes, every person or the people. But as physicians, as clinicians, I think we need to explain, to have a conversation, an open dialogue with our patients, and to inform about what is the best option or not, and if we have other options. Yes, certainly there are more options, but certainly also the 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 rate of response is not the same with non-stimulants that with the stimulants drugs in this case. But
Yeah.
obviously, everyone is special and everyone is unique.
Yeah.
And for someone, perhaps a non-stimulant drug as guanfacine or atomoxetine have better results than other stimulants drug. And for that, it's important to be open mind, not only the patient or the people, but also doctors, and
Yeah.
also doctors to have an open discussion, an open conversation. I prefer more than discussion
Yeah. That's the problem with
with the
all.
patients.
That's the problem with all these protocols and hugely worldwide agreements. And then some doctors who are not so very much into, they get afraid. They only go to the protocol and they forget that they have to accommodate to the individual patient, of course.
We are working in
Yeah.
medicine, psychiatrists, psychologists, uh, mental health in general, obviously, is a clinical aspect, and medicine is not 2 plus 2 is equal to 4. Uh, Everyone is unique, and you can say, okay, in general, in a large populations, can we can have in mind that this treatment will have this outcome or the response, but every people is special and is unique, and we need to be open minded in this case.
Well,
Absolutely.
thank you for sharing that. And then I would like to jump to the more the peer group coaching, the peer group support. That is one special, let's say, method that I know from very close, the 12 steps method. And in combination with the peer group support like Narcotics Anonymous, like the Alcohol Anonymous, Narcotics Anonymous, could you share a bit of your experience or knowledge about the efficacy of it, or anything, 12 steps
Yeah.
and
Hmm.
NA?
Yeah, sure, Hans. There is very good knowledge nowadays about um, the efficacy of the 12 steps for the prevention relapse of addictions, and also this anonymous group with alcohol mainly. They got good results, very positive results in this sense. And in the case with ADHD, there are groups in Amsterdam that we know very well, from the group of Wim van den Brink in the Amsterdam University, that they are working and with positive results with a mixture of prevention relapse for addictions, and also to introducing the modules or the steps for ADHD treatment, psychological treatment. Yes, a combination of the saffron therapy, the cognitive behavioral therapy, and also the dialectical cognitive therapy that is used for borderline personality disorder. Now there are adaptations for ADHD and also ADHD plus substance use disorder.
Uh-huh.
As a summary, I think the most important is to have evidences and to make right clinical trials with good design in order to have a clear response that what treatment is better or not, or in what situation or condition is better or not.
Yeah, yeah. In the Netherlands, if you go to South Africa from the Netherlands to a clinic, you only have to pay your own travel, but the insurance pays the clinic, the rehab clinic in South Africa,
Okay.
or in the south of the Netherlands, or any place for a 6 weeks or 2 months rehab internal clinic, and then with guidance and coaching when you come back, combined with ADHD treatment, etc. So in general, we are positive about it, but there's not so much scientific evidence. Do I understand that right?
No. I write and I agree to. Yes, I agreed with this kind of therapy. Also, we have here in Spain.
Okay.
My advice is that it's absolutely necessary to have research and to have more information and more data about the efficacy and the safety of every treatment that we want to test or to use. Yes, and also I think for the governments and with a public perspective or public health, is absolutely necessary to have more and more resources around Europe to treat people with addictions in settings like you said, to have the opportunity to have a public coverage, to have as minimum could uh, uh, someone can think that is a lot of time, 12 weeks or 4 months or 6 months. That is the beginning of this treatment because we need time. It's not a question of 4 weeks, 3 weeks. No. And also mainly for patients having chronic conditions with addictions. And this kind of treatment, to have the opportunity to have a right detox and a good rehab during months is critical in essentially. My advice, I had very severe patients with opiate addictions, with cocaine addictions, amphetamines addictions also. And the best results were when I tried to motivate the patients. I motivate the patients to do this detox in an inpatient context, to work with the rehab in inpatient context, and later on to have outpatient treatment or also, for example, hospital day treatment. But for doing that, it's necessary a motivational work with the patient to motivate them to. We have opportunities, we can have more options, yes, and also we have these public services, these public departments, yes, to cover the population.
Yeah, to find for a doctor or a psychologist or a family to find the right moment with the right motivation is very complicated. And as we know, motivation is also something in the mind. Neurotransmitter is
and
also.
For that, Hans, I think it's very important. For probably today will be hundreds of families listen, and also people suffering and desesperated about the situation. To having some kid, some teen with addictions, and probably during this teens year age, during the adolescent, they can have the idea that it's impossible and the future is very dark and we are desperate. Please keep in mind that probably at that moment they are not ready or not enough motivated for doing that. It's very important to be clear, to have rules, and to put barriers, not paying anything and not supporting with money every day. to put in barriers saying, okay, we are here. If you want our help, we will help you. And there are resources. Because in some moment, in another moment later on, probably they will be motivated and will be the right moment for doing that. And
Yeah.
for that, as clinicians, we need to be ready for that moment. Okay, you are ready, you are motivated. Please discuss with us, dialogue with us about the possibility that we have.
Yeah, yeah. I've been guiding quite some families of addicted persons, and it's always very the family, the peers also suffer, and if they turn it around and make it more like an open, non-violent communication, then it'll help everybody in the family. So, do you use in your own practice some form of family therapy, mostly systemic therapy? Can you explain for those who don't know systemic therapy, sort of
Well,
the essence of it?
yeah. Well, as probably you can see in my resume, I have a master on family therapy here
Uh,
in Barcelona. Systemic therapy or family therapy uh, has the origin in Palo Alto in California, yes, during this moment of the cybernetic and the origin of the systems. And the idea is that family is a system that everybody interact with the other. And it's obviously if we have someone on the family with any condition, ADHD, cancer, any heart attack, stroke, that illness or that conditions have an impact on the other members of the family in different ways, but have an impact, yes? And one of the origin of this resolution is to have this better, as you said before, this better communication. And that is one of the bases because sometimes we have not the appropriate or the right communication. And this idea to change this style, this communication, to understand better the other and not seeing the other as the guilty and the other as the person that destroyed your life. If you are seeing the other with love and with another different perspective, it's better for dealing with this situation. It's not easy for the families without sometimes without the support of a family therapist or a coach or someone that is uh, uh, leading with this to improving the communication inside the family.
So, okay, that's for therapy and psychology. Of course, it's all about the psychological effects like low self-esteem, which of course develops during early youth, as we know, and negative self-image. But now for some innovation, are there any new things that maybe are not yet totally proven, but are really innovative techniques? I think you mentioned one. It was about stimulation, transcranial
Yeah, yeah.
stimulation. Can you tell something about that?
Mhm. As probably all of you know, that our brain is an incredible network of cells, of neurons communicating each with other. And the basis of this communication is electrical inputs, yes? And we know for, from years and now that uh, it's possible to modify this communication between the neurons with magnetic stimulations, external magnetic stimulation. And also for very severe conditions as obsessive compulsive disorders, very refractory to the treatment, or schizophrenia, or major depression, now we are studying to stimulate in the deep brain with neurosurgical interventions specific areas of the brain, critical areas to improve the release of these conditions. And now is also awesome research, very nice research, testing if with external, not with the brain in the surface of our head, with magnetic stimulation, it's repetitive magnetic stimulation, it's possible to modify the addictions and to modify the risk. And at that moment, several research settings, they got positive results, for example, with measured depression, and also positive results for addictions, mainly cocaine and alcohol.
And what does it do, this transcranial magnetical stimulation? Does it alter your neurotransmitters? Does it make the certain neurons more active? Or what does it really do?
Yeah, that is interesting. We know that this magnetic stimulation stimulate the release of different neurotransmitters, but also to increase the plasticity of our brain, yes? To change the way of the neurons are connected between them, yes?
So that would help, because plasticity means that you make new pathways in your brain. So if you work on the psychological side and the motivational side, that also is a sort of learning in the brain. And so it might, what you say, it may help as a support of learning new psychological coping strategies. Is that?
Yeah, that is true. At the end, pharmacological treatment increase the release of neurotransmitters, of substance in our brain. Also, we know that this pharmacological treatment had modifications on the structure of the brain, but also with psychotherapy. Psychotherapy works because made an increase of release of neurotransmitters and also modify these brain connections. Obviously, when someone has a trauma during childhood, as for example, sexual abuse or sexual harassment, yes, this situation, this condition modifies areas of our brain in terms of the structural and the functionality. And that is the explanation why these situations can increase the risk of other disorders, yes? And with the magnetic stimulation, this general idea is that to stimulate the plasticity and new connections in our brain. But as I want to clarify that as at that moment, we need more research in this topic, but maybe in the next year, this treatment will be available for more patients and for people with ADHD also, and also for autism spectrum disorder.
Okay, well, that is some future perspective then. And I think we can round up. It's almost 25 past 9. So I think energy is getting a bit lower now, at least.
For all of us.
Yeah, for all of us. Well, let me keep it to myself. My energy is getting a bit lower. And but I'm so happy that I've been talking to you and that we can share it with a lot of people. And it, like you mentioned, it will be on the internet on our ADHD Broadcasting ADHD Europe channel on YouTube. So I'm very proud to have been talking to you. I want to thank you very much. I hope we can do this once more when we have, let's say, certain questions or one of the subjects. And thank you for all your time, because what people may not know, it takes a lot of preparation and making a PowerPoint and all phone calls, and you got at least 20 emails from me and from ADHD Europe. So we've been stalking you a little.
No, Hans, thank you for the board of ADHD Europe for this awesome job and this non-profit work in terms of economical aspects, but very profit work in terms of social rights and awareness. And thank you for the invitation. To me, it was a pleasure because it was not a presentation, it was a conversation with a mug of tea, and being here with you is it's a pleasure for me and also an honor. And I hope that in the next future I could share with all of you our new research, new results, and why not in the future with my colleagues from Time Span to present results or present results of Eat to Be Nice about the prebiotic clinical trials that we run in this large European grant, Eat to Be Nice. That is the name of this other grant, or COCA projects. We have at that moment a good moment for the knowledge of ADHD, and also we need more research and also more support from public governments and general governments to support people with neurodevelopment disorders. Thank you, Hans.
Thank you. A lot of hugs and thank yous from the public I see here in the comment statement. So have a good night and hope to see you soon again.
Bye-bye.
Bye.
Take it easy.
Bye.
Good night, everybody.
Be safe. Bye-bye.
Bye.